connected to tubing, and in this case, the machine is on his power chair and it's seated behind him. The difference, of course, is that the gentleman with the tracheostomy will need to have round-the-clock care in order to do this, and he needs to use it round the clock, whereas at least in the beginning, the patient with non-invasive ventilation can use it when they need to, and when they don't need to, they can take it off, and they have more control over it, and it's very easy for their family to use. What that means is that there are a summary of indication, pros and cons for each of these devices. Now, I will tell you, this topic of should I ever get a tracheostomy tube, should I do early initiation of non-invasive ventilation, that topic in and of itself could be an entire hour lecture, and I tell you I have that entire hour lecture. So suffice it to say, I'm just giving you the take-home messages on this point. But the indications for non-invasive ventilation are spirometry, which is the test we do where it's take a deep breath in and blow it out as hard and fast as you can. That blow-out test needs to be less than 50% predicted based on age, weight, sex, and height. The other test is a breathe-in test. Suck in as hard as you can. For that test, it's minus 60 or greater. Oxygen saturation can be measured with a pulse oximeter on the finger. That test is done as an overnight test in the home. If we measure oxygen saturations at 88% or less for more than 5 minutes during an overnight recording, that's another indication. And then the last one is carbon dioxide monitoring, showing a level of 45 or greater. That test is least often done for our patients because until I get a machine in the office that can measure it non-invasively, it requires a blood test into the artery, which we don't really like to do if we can avoid it. So, but occasionally we will have to do that. The pro side is that these devices reduce mortality, they're easy to use at home, and easy to access the equipment with many companies that can help. The con side is that 24-hour use can be supported using a non-invasive device, but may cause air to build up in the stomach, and it needs multiple interfaces so that you don't get skin breakdown. That being said, 24-hour use alone is not enough of a reason to say that non-invasive ventilation won't work. And anyone who's been to our clinic has, I'm sure, seen multiple patients coming in on 24-hour non-invasive ventilation. Invasive ventilation, the indication is actually the inability to handle secretions. Because if you can't handle your secretions, then you really do need that tube in your throat in order to get them out. The pro side is that in a 24-hour-a-day use, it may be easier to be placed in a long-term care facility. If you're using a non-invasive ventilator and you're using it 24 hours, it is difficult for us to find a long-term care facility that's comfortable with that. On the con side, it does have very high costs. It limits access to caregivers in the home. It will prevent you potentially from entering into a hospice program, and it may limit you from being able to stay in your own home, forcing you to be in a long-term care facility. So these are all things that are very unique patient to patient, and this is just a small taste, a small summary of what ultimately becomes a much larger discussion. And I didn't put the data in here, but I think it's important for you all to know that Pat Casey, who's one of our research coordinators in the clinic, many years ago did a study looking at patients making this decision between non-invasive and invasive ventilation, and found that patients with ALS on average change their mind 3 times throughout the course of their disease. So please note that if we ever talk to you or a family member about making this choice, we're not asking for an answer. We're asking for us to engage in what we perceive as an ongoing, continuing discussion, because we know that we are here for you through your journey as you go through many decisions of this process. I wanted to show you a picture of this. This is a form of non-invasive ventilation that we do, but is not commonly available throughout the country. And we feel very privileged to have respiratory therapists like Sherry Dvorak, who's here today, who is our partner in helping to set this up at home. What you'll see in this picture is that the gentleman has a full mechanical ventilator on the back of his chair, but rather than putting it to a tracheostomy tube in his throat, he's just using it through his mouth. We know through good research that this is very effective to reduce CO2, improve speech, and improve cough, and it works very well as an alternative to tracheostomy in those who require 24-hour ventilation. It doesn't work in 100% of our patients, but it works in enough that we are aggressive about offering this therapy to all of our patients. We do aggressive monitoring in the home. The picture that you're going to see here is looking at a device that measures both oxygen and CO2. That little clip on the ear there is a new device called a transcutaneous CO2 monitor. What we love about this is that we can measure CO2 without having to do a blood test. And we also love about it is that it will record for 8 hours. We know that sleep is the most vulnerable time for CO2 to go up, and so we like this as a way of screening our patients to see if they're getting into issues. We also like to use this as a way of monitoring our ventilation support in the home, because we don't bring our patients into a sleep lab if we can avoid it, and instead we can use this kind of remote monitoring. What we love about this, and what I'm going to show you as our other module as well, is that this is a great model for what our country is talking about in general in terms of electronic health and remote monitoring, so that we can help to keep our patients in their homes but still provide aggressive and cutting-edge health care, but helping them to avoid having to come to the hospital as much as possible. Another way that we're doing this now is by using a RAD device, which I'm going to show you a picture of in the next slide, which has a direct access to cell phone towers. It allows us to get direct information about how our patients are breathing. Do their devices fit well? How many hours are they using them? How big are their breaths? How frequently do they breathe? It also allows us to get into the guts of the machine, change almost all of the settings that we need to, as needed, to keep our patients comfortable. And these are the two kinds of devices that we can do this with. The RAD is the one that's right under here, and it's really blown up in size. It's really about this big, and it weighs about 7 pounds, so it's very small. The other device that you'll see on here is a mechanical ventilator. Now, this device can be used either at the nose and mouth, or at the trach. And because of that, its multifaceted nature, it has a lot more sophistication to it. We can still do remote monitoring with these devices using a new modem system that can be hooked onto these, newly available within the last 2 months. We also like these devices because they have battery power in them, so that if someone needed to be mobile with their device, or if they lost power, this would be the kind of device we needed. I will tell you, I just returned from a trip to Miami in which I was meeting with a group very similar to this. But you know, in Miami, there's frequent hurricanes, and loss of power is very common. And in Miami, 100% of the patients get these kinds of devices right from the beginning because of their power needs. Thank goodness here in Chicago, we really don't have that. And so what we like to look at is some of the pros and cons to each one of these devices and how we choose what we're going to pick. The RAD device is less expensive, and because it's so much smaller, it's convenient for travel. And it's much quieter because it doesn't have so many bells and buzzers. It provides better humidity because the humidity is integrated into the device as a single unit. It has remote access and control. The only con is that because it is covered under the Medicare bid, there are fewer companies that will provide it, and so sometimes we need to jump through hoops to get coverage for it that can be a little challenging. But I have Stephanie, and she takes care of my patients. So it's not too bad, but it can be an issue. With mechanical ventilators, We talked about the fact that the battery has good safety and portability, and because of that portability, we can use it for that SIP or mouthpiece ventilation. And it also can be used to help patients breath stack and cough. It can be used in those who need 24-hour use, but it is expensive. And humidity is an issue. We have to get separate humidifiers. If you look back at the original slide, you'll see that the device has a separate device that it's going into. That's the humidifier. Although we can monitor patients, we can't remotely change their settings. And sleep labs are not prepared for these devices at all, which can make them somewhat limiting to some places throughout the country. The other thing I wanted to show you was a report that came out from the Office of Integrity in Government. This came out at the very end of last year, so it's been out for about 4 months now. And basically, that blue line shows the increase in the use of devices that are full mechanical ventilators with mask. And the orange line at the bottom shows that it's just flat, the use of those RAD or smaller devices over the same period of time, which is 2009 to 2015. The cost difference is tremendous. So the top line there looks at the average cost per month on a mechanical ventilator. The middle line shows the average cost per month for a RAD device. So you can see why the government would be concerned at the increasing number of devices that are being prescribed. And what you'll see, and I'm just going to skip to the slide here because this really gets to the point, is that if you compare 2009, the blue part of that chart is the percentage of patients that have neuromuscular disease. The orange part of the chart is those with chronic respiratory failure, which is mostly COPD. If you compare that to 2015, those COPD patients have really taken over, and the neuromuscular patients are getting obscured. Our concern is that the government may tamp down significantly on availability to these devices because of the increasing cost. What we want to make sure is that as that happens, neuromuscular patients who should be top of the list to get these devices don't get lost in the mix. We think things should go back to looking the way they were in 2009, when these devices were predominantly used for patients with neuromuscular disease. These are the patients who really need the sophisticated settings and the internal battery and the portability. And so one of my jobs as the pulmonary liaison for the Les Turner Foundation is to act as an advocate nationally to make sure this is happening. And I just do want to let you know, in case you're reading about things on the internet or whatever, that we are continuing to advocate for our patients. And right now I think that we're safe